Hello, and welcome to today's webinar, Future-Proofing Healthcare, Member-Centric Data Strategies, and the One Big Beautiful Bill Act. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available within 1 to 2 business days. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you are using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today from Century Health Solutions, Don Carter, Senior Director of Health Policy and Regulatory Affairs, Michelle Darnell, President of Secure Exchange Solutions, a Century company, Linda Roman, Senior Vice President of Strategic Account Management, and Rebecca El-Hassid, Senior Vice President of Enterprise Solutions, along with Richard Pridham, President and CEO of Retina Labs US. At this time, I'd like to turn the floor over to our speakers.
Good afternoon, everyone. We are so delighted to be with you today to present what we hope will be an informative session with a focus on future-proofing healthcare. There is still a great deal of uncertainty surrounding the requirements of the One Big Beautiful Bill Act and the timing of their implementation, but we wanted to discuss some actionable strategies that will help you and your organization navigate post One Big Beautiful Bill Act, no matter how murky the future might seem. I'm your moderator, Dawn Carter, and I'm currently the Director of Healthcare Policy and Regulatory Affairs at Centauri, which means I stay very busy these days ensuring that my organization and our clients understand the post One Big Beautiful Bill Act financial and operational impacts. Next, I'm going to be handing the mic over to Centauri's Michelle Darnell, the President of Centauri's Secure Exchange Solutions subsidiary, and Rebecca El-Hassid, SVP of Enterprise Solutions, and they're going to set the stage for the rest of the discussion with a focus on leveraging data and technology as the foundation for effective member-focused strategies. Then we'll hear from Linda Roman, who is Centauri's SVP of Strategic Account Management, and she's going to discuss enhancing member support and insights. And then I'll come back on to discuss some risk adjustment and quality strategies you might consider post One Big Beautiful Bill Act. And last but not least, and arguably the most important, we are going to hear from one of Centauri's partner organizations, Retina Labs, who will provide us with a compelling example of a strategic partnership that leverages data and technology to produce powerful and actionable member insights. We'll then have a panel-style Q&A session where we hope that you'll be able to get your most pressing questions answered or to tell us your thoughts about future-proofing healthcare. And with that, let's get started. All right, so if you're like me, I like to listen to podcasts and read books that kind of feature the top-of-mind topics for healthcare. And a little over 2 years ago, I was listening to an episode of one of my favorite podcasts, the Rich Roll podcast, that was featuring an author I'd become interested in, Dr. Peter Attia. Dr. Attia wrote a book in 2023 called Outlive, The Science and Art of Longevity. And not long after its release, Rich and Peter had a conversation about the book on Rich's podcast. I will never forget that I was listening to that podcast while out on a run, and there was an exchange between Dr. Attia and Rich that stopped me dead in my tracks, such that I listened to the exchange several times on repeat and wrote it down as soon as I could put pen to paper. So the conversation went like this, and Rich says, "We have this monolith that is the healthcare system and its gestalt towards bankruptcy and the costs that are incurred from treating all of these chronic ailments. You would think that there would be more of a financial incentive to front load patients with these types of tests and early detection scenarios to avoid these costs later on, but it's so entrenched that it feels like an impossible task to rewire the system and create better incentives." And Peter says, Right now, my health insurance is Aetna. 2 years ago, it was Blue Cross. 3 years from now, it's going to be United. What incentive does Aetna have today to care about spending $1 on me when they are pretty much positive they are not going to own that risk in 20 years when the chickens come to roost? That's the fundamental problem. It's the portability of risk. Until you fix that problem, until there is true risk ownership between the patient and the payer and the provider that is carried out over the course of their life, there is no incentive for them to carry all of that risk. And of course, the episode is quoted there in case you want to look that up. I mean, I've always intuitively known that what Dr. Attia says about the portability of risk is true. And I think, didn't we fix the problem of portability with the passage of HIPAA in 1996? And the answer is no, not as it pertains to a single longitudinal view of a patient's health and wellness. But the good news is, with the evolution of interoperability and laws related to privacy and security and information blocking, we are getting closer and will continue to get closer regardless of who occupies the Oval Office. Will we be able to solve the problem of risk portability? No, but we can solve the problem of how these systems are able to talk to one another through interoperability. More good news is that interoperability is the key to mitigating many of the risks associated with the recent passage of the One Big Beautiful Bill Act. And today we are going to talk about the member-centric strategies you should consider that would help mitigate those risks. And so next, I'm just going to take a minute to kind of, refresh our memory on our session overview. In just a minute, I'm going to pass the mic over to my colleagues, Michelle and Rebecca, to talk about leveraging data and technology. After that, we're going to hear from Linda about enhancing member support for dual eligible members. Then I'll come back on to talk about driving risk, quality, and care management outcomes. And then we'll end things with Richard talking about building strategic partnerships. And with that, I'm going to hand the mic over to Michelle and Rebecca, who are going to talk to us about leveraging data and technology. Michelle and Rebecca?
Thank you, Dawn. Thanks for that great introduction. In terms of member-centric approaches, plans today have even more reasons than ever before to leverage data and technologies. And it's important as they look to ways to leverage data and technologies to understand what are the pressures that are really affecting health plans across their various programs, and what is steering health plans toward a more member-centric approach, a data-driven approach. And some of those pressures are range from the shift toward value-based care, more risk-based models, reimbursement models that are optimized and that require member outcomes management, care coordination, more real-time alerting and monitoring. All of these initiatives and trends actually require a very strong data strategy and also require some flexibility to be able to bridge what's available today and also look to the future and prepare for the future. So plans can no longer rely on siloed, lagged type data. They really need to be able to look at the member in a much more dynamic and real-time way. So what might a member-centric data strategy look like for a plan? What would it include? It would most likely include an ability to have a unified member source of truth, so that information about the member that comes from a variety of sources could be used and leveraged across multiple use cases inside of the health plan. And that's very key to looking at the member in a more dynamic fashion. It might also include the ability to capture information in a more real-time or near real-time way. So what this could mean is that really a plan needs to have a architecture or a platform that enables to engage and gather information, critical health events. That might be admission discharge data, for example, about a member, along the way that then supports their overarching, strategy. This plan might also include the ability to have feedback loops and provider engagement. And so that means you should use and leverage your data strategy, your data exchange strategy to engage with the provider in a way that is not negative, abrasive, but that engages with the provider in the workflows that they're currently accustomed to. And that also gives you the ability to better coordinate care and close gaps. So you need a strategy that enables you to communicate bidirectionally with providers in their platform of choice, understand what's happening with the member in a more real-time way. And in the end, this leads to providers being able to take action on data, on insights that you're able to provide. That's all part of a member-centric data plan that for a health plan. And then lastly, with all of the focus on compliance and the availability of more and more data, obviously auditability, to be able to have an audit trail, to have transparency around exchange, to leverage, trust networks, et cetera, is very important as part of your overarching strategy. I'm going to hand it off to my colleague, Rebecca, to drill down a little bit more into member-centric models and approaches that we see across our plan customers.
Thank you, Michelle, and thank you everybody for coming. I think that the best way for me to tell the story of how member-centric data has had such an impact and how we've gotten to where we are today is to tell you a little bit about where we started. So I've been working in the healthcare technology field for almost 15 years, and the first 10 years I spent primarily on the provider side. As the providers were, receiving incentives to do better with interoperability, to collect better data, to have the data stored in more standardized ways and be able to exchange it. And so when we started working with health plans, I thought, oh, this is going to be easy. We just need to hook them up one to the other and everything is going to be fine. And we worked with one of our largest health system customers, and we got everybody on board. They started sending automatically complete patient information as encounters were happening to their health plan. And within about 48 hours, the health plan was on the phone saying, oh my gosh, turn that off. And so when we quickly learned that this is not really as simple as interoperability, making sure people are connected to one another. It is really a combination of that ability to be interoperable with the ability to understand and consume the data. So as we dig more into the health plan side, we discover, a few years ago, why they're doing what they're doing. And a lot of that is that health plans on their side of the patient data equation, they're doing a lot of things very manually, and they're doing a lot of things that have a very narrow scope. So what happens is, if let's say they're doing risk adjustment, Dawn's talking about risk, they're trying to identify what a risk level is for a given member. It's going to be a very expensive proposition for them to go send a staff member to go knock on a provider's door, photocopy a chart, type in the relevant information, submit that to CMS, and pass an audit. But because they were doing all of these steps that are costly and manual, they were doing it in a very granular way. And we came in and said, there is a better way. We have done all this work on the provider side in getting this data more holistic, more electronic. What we need to be able to do is not just connect you, again, not just the interoperability component where you can do the handshake from provider A to health plan B, but help you to be able to understand that whole member. So yes, you get your data about that patient, that you need for that patient's risk score for CMS, but also you can get the data about where that patient stands on your other quality metrics. And that really entails, just in terms of the nuts and bolts of it, it entails understanding how both sides of that work. So Michelle talked about this a little. It's very important on the provider side that they're able to use the tools that they are already using. So if you are using your EMR to exchange information, then payers should be able to access that lever to also access information. If people are using their regional health information exchange, which is a terrific thing that many people do, then that is a great hub for that data to be exchanged. So a big part of what we've leaned into is leveraging the existing investments that providers have made in exchange of data. On the health plan side, what is needed is for them to be able to consume that data that often, I would say usually, almost always, involves an intermediary who's able to help them to interpret that data. Every EMR packages their data a little bit differently. Health plans understand data a little bit differently. So it is helpful to have an intermediary to be able to make that marriage work of the data as it's coming out of the provider and it's coming into the health plan. And that enables them to really start to understand their members. And once they start to understand their members, you really break free of this manual use case based approach, which is bad for the providers because it's a ton of work. It's bad for the members because nobody has the whole picture at any given time, and you can't avoid redundant tests and things get missed. And it opens the door to all kinds of uses that actually support member care, because now you have an exchange of data where the health plan understands what the provider knows about their member. Then they can understand, what does this provider maybe not know about the member? Oh, hey, I have this information from this cardiologist. The provider doesn't have that. Let me make sure that we share that back so that the provider knows what medications this patient is on from a different provider, what tests they've had earlier in the year and what results there were of those tests, or what gap that patient has that needs to be closed. The results of doing this over the past couple of years have been pretty dramatic. The health plans that we have worked with have largely completely switched away from their previous approach where they were manually going and looking for a particular encounter from a particular provider, and they've switched to starting first whenever they have a need for data, which there's different reasons for that throughout the year, to first trying an electronic member-based approach. That has helped them dramatically both in their efficiency and in how they are able to interact with their providers. So a big question that always comes up whenever we talk about what this process looks like is about the understanding of the data. So a key part of this, and this is key for all users of the healthcare ecosystem, is being able to consume and understand the data. So both directions. I've talked a little bit about the health plans needing to understand data. Same thing on the provider side. So as plans are able to glean these insights and share them with the providers, it's extremely important that the providers get that data in a way that is not irritating, not repetitive, that is valuable, that is clinical. And so that is really the role that we serve in helping to get people to this member-centric approach, is both making sure that all the connectivity methods can be managed, that's the interoperability piece of it, making sure that the data is consumable by both sides and that everybody is getting what they need where they need it. So I'll move on a little bit to talk about what the network looks like, how this is actually achieved. When you have, one entity in the healthcare space that needs data from another entity. So that's when you start to talk about network. So today, the world of interoperability, when you're talking about exchange outside of, one particular group, going beyond provider to provider or plan to plan, you're talking about what networks exist today. So providers know there's a lot that's been invested in interoperability between EMRs. Some EMRs are able to exchange information quite well. Others are not. They might be on premise and have a difficult time exchanging data in and out of the individual practice where you're residing. HIEs are a terrific mechanism of exchanging information, and they're a very valued partner in the world of data exchange because they are very uniquely able to support some of the smaller providers who are often left out of this type of information exchange, and regional health information exchanges really support them and help bring them in, so they are both bringing value into the system and getting value out of the system. And there are then trust networks. There's some trust networks that are specific to specific use cases. Over time, those are evolving and expanding to be able to meet our larger use cases under HIPAA. And then I'm going to hand this back to Michelle to talk about what TEFCA is starting to shape up to look like as this whole system continues to evolve.
Thank you, Rebecca. So Rebecca's talked about the current availability. The beautiful thing about data is the more and more data that there is still opportunity to actually help to assess and provide insights on that data. Nationally, there are initiatives that are continuing to improve our data exchange. Many of you probably heard about TEFCA and about QHINs. This is really just about providing a even better technical framework for exchanging and to support interoperability. The vision is that TEFCA and QHIN supports multiple use cases. There are already use cases that are live on TEFCA and through the QHINs for individual access and for treatment. So it's an exciting proposition really for the future, for now and for the future, that we all need to be prepared for. And while we're engaging and leveraging the activities that Rebecca's done a great job of summarizing today. So I'm going to hand it back to Dawn for our next segment.
Very good. Thank you so much, ladies. And now we're going to hear from Linda about proactively enhancing member support. Linda.
Thank you for that. And, you know, the exciting thing about the use of technology that Rebecca and Michelle's group provide is the ability to take things that we've been doing in a siloed fashion and be able to integrate it in a way that, you know, is synergistic. So, for example, Centauri has for many, many years, probably 30 years, been doing eligibility services for dual eligible members in the Medicare Advantage space. But when you add in the capability of technology and the ability for us to be able to interact with the larger ecosystem and the ability to know when activities are happening in that ecosystem, really allows us to manage a dual eligible member in a much more cohesive and comprehensive way. And so the exciting thing that we've been able to do with some of our core eligibility services is to enhance them in a way that provides a 360-degree view of a health plan member. So let's take the Medicare Advantage space, for example. And the most vulnerable of that population is a dual eligible member. There are many components of a member's healthcare journey. Clearly, eligibility is critical. If a member presents at a doctor's office or a testing site or for medications and has lost their eligibility, then clearly they can't get the care they need. At the same time, when a member has in fact gone to the hospital, has been admitted or discharged from a hospital, then there's a lot of things that need to happen for that member in order to coordinate their care. So all of those component parts of the member's journey is critical in providing a comprehensive and cohesive healthcare experience for the member in our health plan clients. Now, clearly Centauri works with health plans, and so the health plans have an important role to play. And what we're able to do for our health plan clients is to be able to coordinate these components in a fairly comprehensive way. So what we have been able to do is combine the clinical event monitoring along with our eligibility monitoring and provide a more comprehensive monitoring capability. Example, we get a roster in from our health plan client that includes all of their members. And the critical thing for us to do is watch those members for eligibility events, for clinical events, and to be able to interact with those members at the appropriate time for the appropriate purposes. We want to make sure they have their eligibility intact and continuous. We also want to make sure if there's a clinical event that we provide the kinds of supportive services that are needed at that point. One of the ways that we can do that is when on the rails that Rebecca and Michelle have been talking about, on that communication network and superhighway that we have that exists, when we get a notification about an event, a clinical event that has occurred with one of our dual eligible members, then that notification goes to the care management team, both the primary care provider as well as to the case manager, so that everyone has the information that they need at the right time to intervene on the member's behalf. At the same time, that's an excellent opportunity for us in the eligibility support team to reach out to that member to see if there are community-based services that that member might need also to support their care. When we interact with a member at a critical time, then the relevance of that interaction becomes much heightened and more important, because the member then can see how it all relates to their care. So this is the addition of the clinical data to our processes really allow the service to be a much more comprehensive and a much more time-based, event-based kind of interaction with the member that makes it much more relevant to the member at a given point in time. Now, as mentioned, once we get the event notification, then the notification goes out to the care team. So the care team will get that notification. The primary care provider will get it in his EHR. The care management team will get it on their care management platform. So they'll have the information at the same time we have the information, and all of the care then gets coordinated in a critically important way and a member-centric relevant way, so that it's really important. So the member now can see all the component parts as driving towards supporting them in a critical time that they need the help the most. So what we do know for our health plan clients who utilize all of these component parts is it really drives really important results. Key results include reducing readmissions at hospitalizations. Most of our health plan clients see substantial reductions in avoidable readmission rates because the information gets to all the interactive parts of the ecosystem at the same time so that they can interact and support the member. We've had all of our health plan clients who utilize these kinds of programs also see about a 10% improvement in the retention of members, not just the retention of a key dual benefit, but also just member retention as a whole improves by about 10% for those members who work inside the program as opposed to those members who do not have this kind of supportive service. And so our health plan clients, as well as their members, we believe that because of this synergistic coordination, that it really does speak to the member then becoming a much more sticky member, which allows the health plan overall to see an 8 to 10 times return on investment. So I'll turn it back to you, Dawn, to talk a little bit more about some other use cases.
Very good. Thank you so much, Linda, for that exploration of the member insights that are so critical to access to care. So as promised, I'm going to talk to you a little bit now about risk adjustment and quality strategies. So we know that in this post One Big Beautiful Bill Act world, we're going to need to make some tweaks to our strategies. And this will have to be done so that health plans and other entities can ensure they're fully leveraging the electronic capabilities that we have been discussing in the interest of true member centricity in this environment. So this is going to start by kind of setting the stage, like Rebecca did, by saying, I've been in healthcare for a long time, and in risk adjustment particularly, which I've been involved in since about 2010, the focus has been largely retrospective, which is why our slide says it's a traditional retrospective focus. It's been claims-based and doesn't really incorporate multiple data sources. They rely heavily upon administrative data, which is, billing focused and doesn't really include clinical insights. There's some limitations to this, and a lot of you probably know what those are. They miss clinical nuances, such as lab results, care plans, social determinants of health, a lot of the data that Linda was talking about. It ignores the real-time inputs that Michelle was talking about, like wearable data, pharmacy refills, behavioral health, a number of other sources. And it limits the ability to predict risk or personalize care, especially not real-time. And so that's kind of limitations of that claims-based focus. Also, as Michelle mentioned, the traditional focus relies upon lagging indicators. So the data reflects things that have already occurred, often weeks or months later, and it's really too late at that point to affect any change in strategy. And so the limitations is there's delays in identifying those high-risk patients or care gaps, patients that Linda talked about, those really vulnerable ones particularly. It's reactive rather than proactive care. And it's really poorly aligned with value-based care models that require timely intervention. And those are the ones that Rebecca discussed. So these reactive interventions, we of course know that means, actions being taken after a problem arises, like a hospitalization, a missed medication. We know the limitations of those are higher cost results due to emergency care or avoidable complications. We also have missed opportunities for early outreach or care coordination, and that certainly undermines population health management goals. And also, this data is typically not multi-use, as I mentioned, and is used for a single purpose, like billing or compliance. The limitations of this is when it's not multi-use is it can't be repurposed for things like quality improvement, risk adjustment, or even member engagement. It requires redundant data collection across departments, and we know that duplication and redundancy is not a great thing in this context, which all of this increases administrative burden and reduces agility. And going back all the way to my beginning slide, this type of data is very fragmented, and it is certainly not longitudinal as we are pushing forward towards that longitudinal view that we want. Data is scattered in these environments across systems, and it lacks a continuous view of the member's health journey that Linda talked about. And that's what, again, Rich and Dr. Attia were talking about in their podcast. And a lot of us may have even experienced this when we visit providers who don't use the same EMR systems. I know where one is using Privia and one is on Epic, and here's another one that's on some homegrown system. Or have providers who are very risk averse when it comes to data sharing due to privacy and security concerns that are very valid. But we know there are limitations to this fragmented situation, and that limits the ability to track outcomes over time, measure impact of interventions, and certainly get to that longitudinal view. And so what we're going to talk about is pivoting more towards a prospective strategy. Not that retrospective goes away, but we're pivoting more towards something that is prospective. So traditionally in risk and quality, when someone says prospective, and this may even be happening to some of you right now, our minds automatically go to in-home assessments or wellness examinations. And those things are certainly an important part of a prospective strategy and always will be, no matter what happens or doesn't happen with regulations such as the One Big Beautiful Bill Act. However, we now need to think beyond that. Interoperable technologies and tools enable a much more robust prospective risk and quality strategy that will be needed for true member centricity. And later, you're going to see an example of this from one of Centauri's client partners. Now, we know that the key goal here is what you see in bold at the top of the screen. It's blending technology and human touch for true member centricity. And we do this by gathering those longitudinal member records via multi-source data. And hopefully, TEFCA will be the norm in which we do this maybe within the next 18 to 24 months with the collection of this data enabled by interoperability. Members will have access to their own data, which aligns with HR1's push for consumer responsibility and taking control of their health and wellness. That was a stated goal of the One Big Beautiful Bill Act. Also, we know that AI-driven insights are critical to this because they can help us better predict the risk and the burden of illness, identify untreated conditions, and flag gaps before they result in non-compliance or adverse health events. It is also important to emphasize that although the current administration has minimized the priority of health equity, that does not mean its impact as a significant cost driver is likewise minimized. If anything, its importance increases, given that 80 to 90% of health outcomes are socially determined. There are still various quality measures dedicated to health equity. Collecting this data has proven to be a challenge, but AI-enabled tools can flag these conditions in both structured and unstructured data. Also, we want to recognize the importance of PCP care extenders in this dynamic, nurses, community health workers, and others that support care beyond clinical settings, and we need this data to help members stay engaged in their care. And also, we can't stress again, this is how we blend the technology plus the human touch for that true member centricity that we desire. All right, moving right along. What are some barriers to this? You're like, oh, this sounds great. How do we do this? And I say, is this your organization? Bureaucracy, silos, fear of failure. We know that, of course, with especially large organizations, these processes are often hierarchical, compliance heavy, and risk averse, and they lead to delays in adopting new strategies. And of course, we know the impact of this is innovation stalls due to lengthy approval chains and committee reviews, bureaucracy. Pilot programs and data sharing initiatives can be delayed or even deprioritized. There's still a lot of regulatory uncertainty. So why would you want to invest a lot of work in something that might go away next week? Especially, as I said, we know there's still a lot of uncertainty around the requirements and the timing of them for the One Big Beautiful Bill Act. This can cause a form of paralysis even when action is needed. And so sometimes we've seen examples of this where health plans might take months to approve new interoperability vendors or data sharing protocols, and they miss windows of opportunity for things like RADV or HEDIS optimization. So bureaucracy is the first barrier. The second one is silos, and we actually heard that mentioned earlier multiple times with fragmented data and teams. And what this typically means is that departments operate in isolation with limited cross-functional collaboration. So what this results in is incomplete or inconsistent data, which makes it really hard to build that longitudinal member view that we so desire. Teams might even be using different tools, standards, or definitions, which leads to misalignment. Strategic initiatives such as prospective risk scoring or even SDOH integration are undermined because there's no shared ownership. And we've seen examples of this where actuarial teams, for example, might be building risk models without input from care management that result in scores and data that really don't translate into actionable interventions. So again, silos are the second barrier. The third is just fear of failure, being risk averse in innovation. And this usually means that organizations hesitate to adopt new models due to uncertainty, compliance concerns, or maybe just failing in the past and being very risk averse. So this, of course, can result in the avoidance of anything AI related, especially the analytics that Rebecca was talking about, predictive modeling, or even use of non-traditional data sources like social services data, wearables data, anything. And we need that data, to build the most robust longitudinal profile that we can. Also results in missed opportunities to proactively identify high-risk members or optimize coding before submissions deadlines and to stop some of that scrambling that happens at sweeps time, for example, or when a RADV happens. Also, an over-reliance on retrospective methods is risky. Like I said, we want to shift even when prospective strategies offer a better ROI and member outcomes. We don't want to over-rely on those strategies in this landscape. And a good example of this is when plans avoid implementing real-time risk adjustment engines and care gap closure opportunities that are real-time due to concerns about CMS audit exposure, even though it could improve accuracy and result RADV penalties in the long run. So that's just kind of some barriers that we see and challenges as we're out in the industry. So what does the prospective strategy value proposition look like? And to encapsulate it, when I was working with a colleague on the content for these slides, we kind of distilled it down to, and again, you've heard all of us kind of say this in just a different way, is data is only data until it is made actionable. And like we said, traditional systems often silo data for single use, like claims used for billing. A prospective strategy leverages multi-use data, meaning the same data stream can support various processes. It can support risk adjustment and accurate coding and member stratification needed for proper reimbursement. In quality improvement activities, tracking HEDIS measures, stars, and care gaps. Care management, identifying high-risk members and coordinating the interventions that they need that are very specific to the population. And a good example would be, a lab result that indicates uncontrolled diabetes. This can trigger a risk adjustment flag for coding. It can count towards a quality measure such as hemoglobin A1C control and alert a care manager to engage the member. So multi-use data. Now, we have to consider that we need to get the appropriate mix of predictive targeting versus retrospective review. So it's not too heavily on one or the other. And a balanced strategy uses both. So predictive targeting uses AI and real-time data to forecast risk and intervene early. And the retrospective reviews are balancing that, and those validate past care and coding for compliance and audit readiness. And of course, we know this matters a great deal because I'm sure everybody who is here understands that everybody's going to be getting a RADV. So need to be prepared for that and ensure accuracy and regulatory alignment. And then the predictive targeting piece improves timeliness and member outcomes. So timeliness of data is greatly improved with these prospective activities. So a good use case, I wanted to include a good one for prospective targeting through EMR integration. And an example of a workflow might be that a member gets flagged by a predictive model for a potential care gap, like maybe they're missing their diabetic eye exam, going back to our diabetes example. That gap can get pushed directly to the provider's EMR via a FHIR or HL7 integration. The provider sees that alert during the visit and can close that gap in real time. And then the system captures the encounter for risk adjustment, quality reporting, and RADV readiness. And so we know, of course, now the benefits of that are faster gap closure, improved coding accuracy, reduced audit exposure, and just an overall better member experience. And my closing slide is just some strategic takeaways for what I was just talking about, and that is at the heart of a successful prospective strategy is interoperability, the ability to seamlessly exchange and act on data across systems, teams, and care settings. Like Rebecca said, it's not just about interoperability, but it's acting on that data, it going to the appropriate places so that it can be acted upon. And we know that it enables early identification, it supports risk, quality, and care management, and that longitudinal view that we desire. And success begins with acknowledging the internal and external obstacles that I talked about on my barriers slide, whether it's bureaucratic inertia, data silos, risk aversion, and they all have to be addressed through organizational alignment, change management, and technology enablement. And there are a lot of technology partners that can help with that. Such partners can address the challenges of shifting to that prospective strategy as well. So if help is needed in that way, you need to figure out a strategy that goes with what's happening retrospectively. A lot of partners are available that can do that. Now, plans have to choose technology partners that do more than just aggregate data. Again, they have to activate that data. And they have to be able to push those insights directly into EMRs, which enable providers to close gaps at the point of care. They need to be able to support RADV readiness by aligning coding, documentation, and audit trails. They have to enable predictive targeting that drives timely outreach and measurable impact. And the right partner, I can't say it enough, turns data into actionable intelligence, helping plans act and not just react. And now I'm going to turn the floor over to my colleague, Richard, who's going to give us an example of a strategic partnership that kind of brings home everything that we have presented heretofore. Richard, take it away.
Well, great. Thank you very much, Dawn. It's a pleasure to be here with all of you today. In my segment of this webinar, I'm going to talk about a very specific use case of how we've partnered with Secure Exchange for delivery of medical test results to primary care providers. Before diving into that, for those who don't know anything about Retina Labs, I thought I would take a moment to share with you all who we are and what work we do for health plans. For over a decade, Retina Labs has been a leader in the area of diabetic retinopathy screening and preventive healthcare screening. In 2020, we brought to market a new care model whereby we would partner with health plans to deliver these services to non-compliant members on an in-home basis. So these are tests that include, for instance, diabetic eye exams, bone density scans, blood pressure checks, as well as hemoglobin A1C, kidney health, and colon cancer lab testing. So we partner with health plans to really enable them to close gaps in care, to improve their HEDIS scores and star ratings, and also to reduce their long-term costs through better disease detection and care management. This is a high-level overview of our in-home care model workflow, and everything starts with receiving the eligibility data from the health plan. So the health plan will go into their systems and essentially pull the members who have open gaps in care for the different tests that we provide, and that information comes to us in a secure manner. We will then engage with those members through a multi-channel approach and largely led by telephonic outreach, where our team will contact those members, present them with the in-home service offering that is covered and included in their health coverage. We will handle all of the scheduling, home visit coordination. We will go into the home to carry out the requisite tests. In the case of retinal eye exams, that means collecting the retinal images or getting the member to comply with a certain lab test. And also post-encounter, we communicate those test results to the member as well as their attributed primary care provider. And this is really a key pain point in that it is very, very important for us to be able to communicate those test results to the primary care provider. You know, and the traditional way of doing that is either using fax. Still in 2024, 25, fax machines are still the rage for transmitting of test results. And if it's not fax, it's mail. But there's a better way, and Secure Exchange's Notify solution allows us to integrate their technology into our platform, which is called Comply Hub, which allows us to deliver those test results in near real time to those providers in a secure, near real time manner. And lastly, you know, we're essentially a technology-backed service company. And our platform is called Comply Hub, and the health plan has full access and visibility into the success of this screening program. And so it allows them to essentially gain insights around the program's success, as well as the ability to view individual and aggregate test results for their members. So the way this works is that once a test is resulted, we then, through an automated integrated API with Secure Exchange, we verify if the member's attributed primary care provider is enrolled in Direct Trust. Now, Direct Trust is really the interoperability framework and messaging protocol that Secure Exchange is built around. So if the provider is enrolled in Direct Trust, that means we have the ability to deliver those test results to them in near real time through secure electronic messaging. And essentially, the provider will be able to also get those test results in their EMR system, because the Direct Trust system and Secure Exchange interoperates with just about all the EMR systems. So it goes right into the patient record in the EMR system. So that really allows us to ensure the delivery of the results, in a quick manner, and this is especially important for cases that require follow-up and physician referral. So Direct Trust has proven to be a very reliable method of test result delivery. I think it accounts for about 60% of our test results being delivered. There are cases where the provider is not enrolled in Direct Trust, and of course there's a cascaded failover measure that kicks in where we can send the results by fax, and if that's not possible, or if it fails, then the results will go out through essentially U.S. Postal Service. But the bulk of the test results are going out through Secure Exchange, which is really excellent, and we're seeing those numbers increase with every passing month as more and more providers become aware of this Direct Trust option. And I believe if you look at the numbers, there are over 200,000 or 3 million addresses in the Direct Trust network, and I think that represents, hospitals and health systems. I think 9 out of 10 hospitals are capable of receiving secure direct messaging. So it's really become an effective tool for test result delivery. So if you look at the results, we've conducted, since we launched our in-home care model, we've conducted over 30,000 home visits. These are largely home visits centered around the diabetic eye exam. We've closed about 63,000 gaps in care. If you look at the diabetic eye exam piece of it, about 14% of those members have some form of diabetic eye disease that requires ophthalmology referral. So we're talking about 2,200 vision-saving ophthalmology referrals, and some of those referrals require fairly quick turnaround times for consultation. So if you look at some members that have, proliferative retinopathy with macular edema, that is a 2-week referral window. So the quicker we can get the test results to that provider, the quicker that the patient can be seen by the appropriate eye care specialist for follow-up and treatment. So it's largely been very, very effective as a means to deliver these test results. And that's it. That's our use case with Secure Exchange.
Very good. Thank you so much, Richard, for taking us through that most excellent example of a strategic partnership. And now we're at that point in our presentation where we're going to entertain some Q&A. In case you would like our contact information, it's there, mine and Richard's for Retina Lab. But we're going to jump right into some Q&A, and so please feel free to pop your questions into the Q&A, and we'll do our best to get them answered. And we're going to start with a question for Michelle and Rebecca, and the question is, what are the biggest barriers to achieving real-time data exchange across EMRs, HIEs, and other platforms, and how are you addressing them?
Sure, I can take that.
Okay.
I think that the biggest barrier today, a few years ago, that question would have been that we're not doing a good enough job exchanging the data. There isn't enough data available for exchange. And I think that has evolved to be really the opposite challenge, that people have gotten quite good at storing their data and being able to exchange it. And now the biggest challenge is, how do we exchange it efficiently? How do we know what has been exchanged, what hasn't been exchanged, what is a duplicate, what is not a duplicate? How do we make sure that we are keeping ourselves from getting too out of control with cost of storage and cost of understanding and consuming and all that data that's out there? I think it was a problem that a few years ago we would have hoped would be our problem. So I think we're in a pretty good situation. That's the challenge that we're facing today. And now we need to evolve to really not just be able to understand in the midst of a data exchange what is going on with the member, but really be able to store data at a member level, deduplicate data, understand that data coming from different sources may really be the same, and when it's not the same and it may contradict, having an ability to reconcile that, which on the provider side you're in pretty good shape for, because the EMRs are fairly good at doing just that. But the EMRs, I think, are far ahead of the other parts of the healthcare ecosystem in that particular arena.
Very good. Thank you. Thank you for that, Rebecca. The next question, I think, is for Linda. And the question is, how might predictive member monitoring evolve to include behavioral health indicators or social isolation metrics?
Well, certainly as we interact with members and as we get more data from the providers electronically that can go into our analytic models, those elements can be utilized in our predictive analytics. Also, by communicating back with the provider can also be aware of the interactions that we're doing, especially so for example, in our dual eligibility program, where we also have a social determinants assessment called Social Service Plus, where we actually collect information from the member about their social indicators, whether there's food insecurity, housing insecurity, some of those kinds of things. And that data can be fed back to the provider, to his EHR, his or her EHR as well. And so the exchanging of that information and having it be a part of the analytic model can certainly help us with being able to interact more appropriately with the member in a way that will work for the member, so that the member gets the kind of support they need.
Very good. Thank you, Linda. The next question, I think, is for me. And that question is, how can health plans balance the need for rapid innovation with the regulatory caution required in the post One Big Beautiful Bill Act environment? So this one is all about balance. Like I talked about balancing retrospective and prospective strategies earlier. It's about balance, and you want to have a dual strategy to balance innovation and compliance. On one hand, health plans have to foster a culture of experimentation, wanting piloting new technologies like AI-driven risk scoring or real-time EMR integrations in controlled environments. On the other hand, they really need robust governance frameworks that include legal, compliance, and clinical oversight from the outset. You have to have all three of those. One effective approach might be to create what I call a regulatory sandbox, where new models can be tested with limited exposure. And this allows also simultaneously engaging regulators and auditors early in that process to ensure alignment, getting that feedback. So strategic technology partners like Centauri and others, play a key role in offering tools that are both agile and audit ready, helping plans innovate without compromising their regulatory integrity. All right, let me see what other questions that we have here. We have, I think this one's going to be, again, for Michelle and Rebecca. And we have, let's see, how do you balance the need for interoperability with the complexity of managing multiple standards, such as FHIR, TEFCA, and direct trust?
Carefully. No, it's a complex world, right? I think we really push or are looking at constantly in terms of interoperability to meet each party at where the party is. And so what that means is you actually have to operate across this grid of different options. So a provider may be, have a sophisticated system, as Rebecca mentioned. A provider may have some homegrown or no system. That means we've got to meet them where they are. They are on different, streams of interoperability capability. Same on the plan side. So flexibility is key. There's no one-shot answer, and We really keep and maintain this mission of, hey, meet folks where they are.
Very good. Thank you so much for that, Michelle. And we have actually come to the closing of our time together today. And I'm going to turn it back over to Ashley for some closing remarks. But on behalf of Centauri, we want to thank you for joining us today. Ashley?
To our speakers, thank you for the great presentation and for sharing your thoughts. Thank you to the audience for participating in today's webinar. This concludes today's presentation. Thank you again and enjoy the rest of your day.